super excited to introduce Christine Årdal to you. Christine is a senior advisor right now with the Norwegian Institute of Public Health. She has a fascinating career, really spanning the public and private sectors. She has been at the center of virtually every major initiative in Europe around AMR. She was co-lead for Drive AB, that's driving reinvestment in R&D for antibiotics. This is part of Europe's IMI, which is the Innovative Medicines Initiative, aimed at understanding ways that policymakers can stimulate innovation, sustainable use, and equitable availability of new antibiotics. And she currently co-leads the research and innovation portfolio of EU JAMRI, that's Europe's Joint Action on Antimicrobial Resistance and Healthcare-Associated Infections. If these acronyms are meaningful to you, you are clearly an aficionado of antibiotic drug discovery. And if you don't know about these acronyms, then you're clearly in the right place to learn more. We are super lucky to have Christine here today to talk to us about AMR.
Thank you, Eric. That was very generous. It's okay.
I'm not trying to steal your thunder.
I heard that you were a multidisciplinary audience, so I'm going to take a step back, all the way back, to talk about what are antibiotics. So for those of you who already know this much better than me, because I'm not a clinician and I'm not a microbiologist, I apologize. But I think it's important to talk a little bit because some people don't really understand these concepts. So antibiotics are medicines used to prevent and treat bacterial infections. You don't take an antibiotic for a virus. You don't take it for a cold. You don't take it for COVID. So that's very important. And hopefully, probably everyone knows that, so I apologize for if I'm dumbing down the conversation. Now, antibiotic resistance that occurs when bacteria change over time, and they no longer respond to the antibiotics. So it's not, I don't become resistant to antibiotics. It's the bacteria that becomes resistant to antibiotics. And often we say it's because of overuse. But you heard Dr. Kumar's excellent presentation, and you hear that there's a lot more factors involved here. It's terribly small font. You don't have to read this, so don't worry. But there was a global burden of disease study that came out earlier this year, looking at antibiotic resistance. What is the mortality here? And what this tells us is that 5 million people, they think, this is a modeling exercise, so this is an estimate, 5 million people globally died with an antibiotic-resistant infection in 2019. 1.3 million died from antibiotic resistance. So that's quite different, and it's important to know that people are dying with resistant infections, but not from them. And if you look at the bottom chart, which you definitely can't read, sorry, you'll see I've circled 2. And one of those, these are the places that have the highest resistance numbers. And the second to the worst is South Asia. But the last is sub-Saharan Africa. So more people are dying in sub-Saharan Africa than any other region of the world, they think, from antibiotic resistance. But we also know a recent report came out to show that actually we're not getting great surveillance data from sub-Saharan Africa. So these estimates have wide ranges because the researchers said that we're flying blind when it comes to surveillance of antibiotic resistance pathogens in 14 sub-Saharan African countries. But they also told us in this study that in these 14 countries, they use 70% of antibiotic consumption is for antibiotics. So that's very concentrated. And if you compare these 4 antibiotics with the infections that they say that people are dying from in sub-Saharan Africa, they don't match up. People are dying of carbapenem-resistant antibiotic infections in countries that don't have access to carbapenems. So I think on Dr. Kumar's point, infection prevention and control, having access to clean drinking water and sanitation systems is vital here. This is one of the most cost-effective interventions that we could do. And I know we've heard a great presentation, and generally people, they don't want to talk about IPC, don't want to talk about sewage, we don't want to talk about these things. But working on those types of interventions will have wide-ranging impact on a whole variety of infectious diseases. So this is so important. So I hope that you all come away today after Dr. Kumar's much more excellent presentation that this is so important, and this is really, we need to start doing much more here. So I'm going to talk about antibiotics, and there are shortages of antibiotics. This is a global problem. Here's 3 relatively recent reports that have come out about this, one from the WHO, one from the European Commission, and then an article, a global article, looking at antibiotics shortages. Now, why should we care about antibiotic shortages? Because antibiotic guidelines, those guidelines that physicians use to help him or her decide which antibiotic to prescribe, are often based on what antibiotics are available in country. So they don't put antibiotics on the guidelines if they're not available in your country. And this creates a vicious circle. So the prescribing guidelines tell the physicians or help the physicians to determine what they should be prescribing. The sales, that makes a market, they stay in the market, and then that determines the guidelines. So it goes around and around. Now for small market antibiotics, like narrow spectrum antibiotics, this is a problem. So when we talk about spectrum, we talk about how many bacteria we kill. If it's narrow, it's more targeted towards the infection that hopefully is causing it's the bacteria that's causing the infection, and we don't kill helpful bacteria or commensal bacteria. So what happens is when you have you have the narrow spectrum antibiotics that have a small market, they don't make enough money, they don't stay in the market, and they don't go in the guidelines. But when you don't have access to narrow spectrum antibiotics, you also increase the resistance pressure. You can increase antibiotic resistance. So I've taken some data from Canada and Norway, so I'm from Norway, and just had a look at this. Now, as I said, I'm not a microbiologist, I'm not a clinician, so I'm not trying to make any statements here, but I just thought it would be interesting to compare. So I've taken data from 2019 for 3 antibiotics. These are antibiotics that are widely used in primary care. This is probably what you get when you go see your general practitioner if you come in and need an antibiotic. So there is phenoxymethylpenicillin. This is a narrow spectrum antibiotic, so kills fewer bacteria. Amoxicillin, which is broad antibiotic, and amoxiclav, which is the broadest. So these are 3 substitutes, in a way, antibiotics that you can use to treat similar infections. And if I say anything wrong, please do correct me, because I know there's a lot of clinicians and microbiologists here, so feel free. But you can see here, in Canada, you use mostly, so Canada and Norway, firstly, this is per capita consumption. So we use about the same amount, right? It's about the same. Even Norway's tiny, right? We're only 5 million people, so we're a small country. But we use about the same. So in Canada, it's mostly amoxicillin, then next with amoxiclav, and then least with phenoxy. Whereas in Norway, we use most phenoxy, and a little bit of amoxicillin, and almost no amoxiclav. So there can be very good reasons for using broader spectrum antibiotics. It can be resistance profiles, there can be a lot of things. It might be, you have to take 4 pills for phenoxymethyl penicillin every day. So that's a little bit more than you do for the others. But it also could be that phenoxymethyl penicillin isn't available. It could be that the physician, the Canadian physician that wants to use this antibiotic doesn't feel like a prescription is a good idea because the patient might not be able to get a hold of it at the pharmacy. So if we look at the child formulations for these 3 antibiotics, so your children are going in to the doctor and need an antibiotic, and the physician would like to prescribe one of these. Well, in Canada, there are 4 different marketed products of amoxiclav. There's 6 different for amoxicillin, and there is no oral suspension for phenoxymethyl penicillin in Canada. So the physician's right. He or she could not prescribe that because the patient wouldn't be able to get a hold of it. There is one adult formulation, though, for phenoxymethyl penicillin. And so in Norway, we've got a long tradition of using narrow-spectrum antibiotics. And they come under this caveat of what we call forgotten antibiotics. These are old antibiotics that a lot of countries have forgotten about. They say, oh, we can't use those. We should use newer, better, broader, easier antibiotics. And so this is 39 countries, including Canada, and where these antibiotics are available. And the circled ones are the ones that we like to use in Norway. So you can see that, we can't see, sorry, the font's too small, but phenoxymethyl penicillin's on the bottom. So it's available in most of the countries, but not all. And just to tell you a little bit more about this, so this is our most consumed antibiotic. It was introduced after World War II, 1948. The maximum pharmacy price in Norway, so the maximum amount that the supplier can be paid for this antibiotic is 36 kroner, which is $4.60. Now, in Norway, I can't buy a cup of coffee for that, but I understand that maybe here at, what was it called, Tim Hortons, you can maybe buy a cup of coffee for that. So, but that is dirt cheap for our most used antibiotic that we're dependent upon. We only have one company that has a marketing authorization for this antibiotic, and it's from 1971, the year I was born. This company's been serving Norway for 51 years. So, and the other that we had left the market because it's not profitable. They're not making money off of this product. 5 million people, we use a lot of narrow spectrum, but still, we don't use a lot of antibiotics like Canada. And then we have also a list. The Norwegian Medicines Agency puts out a list and says, we really want these products in our market. These are so important to us. Can you please bring these products to the market? And if you look at them all, they're all child formulations. So these are our most vulnerable, our children, where we want to have appropriate antibiotics for them. And they're not available. But at the same time, we spend less than 7.5 million kroner per year on childhood antibiotics. That's less than 1 million Canadian dollars for all children in Norway on all antibiotics. So we're not really saying, okay, we're willing to pay. Norway has some oil. You know, we should be able to put out some money there and to start paying to ensure that our children get the right antibiotics. And if we had the top one, we probably would get rid of that amoxicillin consumption completely, because if you don't know, phenoxymethyl penicillin tastes terrible. It tastes awful. And so if you're going to put it in a drink formulation, children don't want to have it. And so what they want to do, the doctors, the pediatricians, want the tablet available so that they can mush it up in jam and feed it to their children, and so that they don't taste it. So shortages are a challenge for resistance. We did some work in this alphabet soup that Eric so nicely presented, the EU joint action, where we talked in depth with 13 countries, including Canada, 10 European countries, Canada, Japan, and South Africa. And we found that shortages is resulting in greater use of broad-spectrum antibiotics. So that means physicians are being forced to use broader spectrum than they otherwise would like. And what's happening is it changes prescribing habits. Because if you're a physician and you know that probably that narrow spectrum antibiotic that you want to use is not available, you stop writing prescriptions for it. You start writing prescriptions for those that you know are available. You don't want the patient to come back. You want the patient to get the right medicine. And also, in 8 out of the 13 countries, companies decided to stop marketing an important antibiotic. They said it's not profitable. We can't keep these antibiotics in the market, and therefore we can stop and you can move over and use something that's broad spectrum that's equally efficacious. And you can see some of the examples here, and you see that many of them are narrow spectrum antibiotics. And you know what? They're right. They're not making much money. Sandoz is the largest producer of generic penicillins in the world. And luckily, they're located in Austria, so they're not too far away. In 2017, their sales went down 2% from 2016. But in 2021, they went down 12%. So Sandoz is continuing to lose money every year on anti-infectives because Norway and other countries aren't willing to pay more than it costs for a cup of coffee for these vital antibiotics. So there's more and more shortages, but they often come as a surprise because we don't really know so much about antibiotic supply chains. So there's quite a famous example. If you live in our world of antibiotics, this is talked about quite a lot. But there was a global shortage of a key antibiotic, piperacillin tazobactam, hospital antibiotic, that was caused by an explosion at a Chinese factory in 2017. So the active pharmaceutical ingredient, so one of the very first parts of the production process, there was a fire, an explosion. And then it had to come through the pipeline to find out that, to the hospitals, to find out that there was suddenly no PIP/TAZ available. But nobody knew that we were completely reliant on this one Chinese factory. Transparency in the system is not there. You don't know who's supplying your API. Do you have multiple suppliers? Do you have geographically diverse suppliers? Where are they? What can you do about them? So in Norway, this PIP/TAZ shortage lasted 33 months, almost 3 years. And if you don't have PIP/TAZ, you get more antibiotic-resistant infections. You get a lot of C. difficile by using others. Now, it's complicated, of course, to make antibiotics. You have to go through many steps. You have to first start with the raw compounds, then you go to intermediates, then there's active pharmaceutical ingredients, and then the product is actually produced, and then it's marketed and all of that. So it's a lot of steps. So what can we do to strengthen the supply chains of the antibiotics that we're dependent upon? So in Norway, as I said, we have one marketing authorization holder for our most used antibiotic, phenoxymethylpenicillin. Now, the regulator knows who the finished product manufacturer is, and the regulator knows who the active pharmaceutical ingredient producer is. But it's on a piece of paper, buried and inaccessible. It's not publicly available. That's the same in Canada. You have one marketing authorization for Phenoxy for a 300 milligram tablet. We know who the marketing authorization holder is. Probably the regulator knows the finished product manufacturer and the API, but nobody else. And the thing is, you know, if Norway, the regulator, called up the Canadian regulator and said, you know what, we really want to know if we're dependent upon the same companies, they couldn't tell each other because this is considered confidential information. So regulators, we can't call Sweden and say, hey, you know, are we dependent upon the same companies? You'd have to say, nope, sorry, can't tell you. But in New Zealand, you know, when they went forward and decided to implement their online system, they said, well, why wouldn't we make this public? You know, doesn't it make sense? Wouldn't it be good to have this information public? And so it is. So New Zealand has 2 marketing authorization holders for phenoxymethyl. They have 3 finished product manufacturers, and we know that they're located in India, Ireland, and Italy. They have 3 active pharmaceutical ingredient manufacturers, and they're located in Austria, Slovakia, and Sweden. We know who they are. We know which company it is. We can map it out. We can find out how dependent are we on specific suppliers. And do we know their economic situation? How can we help them? How can we have a diverse and sustainable supply base? So supply chain transparency is something that we really need if we want to design proactive interventions to ensure that we have continued access to our antibiotics. So there's a couple things, other things that we can do as well, and I think the obvious one is that we can pay more. We can start paying more for our important antibiotics. Now, Denmark, Iceland, and Norway in the hospital sector has started to do this. So in 2020, they put out a tender. So most hospitals use tendering situations. They put out a tender and say, we need these products, you know, and then it's 100% based on price. Who's going to give us the lowest price and ensure that to get these antibiotics? But they said, you know what, we're tiny. The population of these 3 countries is 10 million people. So we're not, less than a quarter of the size of Canada. But we said we can't rely solely on price anymore. So what we want to do is we want to base 50% on reliable delivery and user preferences, what the hospital doctors want, 20% on price. Price is 20%. It is not going to determine who wins these tenders. And 30% is on good environmental practices, because we know, unfortunately, that some generic producers of antibiotics have problems where wastewater from the factory is going into the water sources. Now, we can't say that for our 30%, you have to have this, this, and this in place and have excellent practices, because then we would have no phenoxymethylpenicillin, because probably no one can meet current standards. But what we've done is we've said, we want you to work towards environmental good practices. We want to work with your leadership. We want to show that you have continued action and plans in place to improve your environmental profile. And this has gone quite well, actually. So the results is suddenly we have more people that want to serve the Danish, Icelandic, and Norwegian markets. So we had an increased number of bidders. There was a unit cost increase, but we expected that. But they said it wasn't due to the environmental practices. It was more about the supply surety, which is okay. And the feedback from industry is that higher prices have helped them to maintain the production of these older antibiotics. And it's useful to demonstrate to their headquarters that this is what's happening. Environment's important, and we need to start working on this. So this has been quite successful. And just to segue into Kevin's next presentation, I want to say that it's not just old antibiotics that we have access problems to either. So these are the new antibiotics that have been approved since 2010. And sorry, again, terribly small font, but all that white space in there so the columns are how many days it's taken after the first regulator to approve before it hits the market. Now you can see Norway as kind of the one with the little green in the middle there. You can see that Norway, we don't have access to a lot of antibiotics, and Canada's all the way on the far right. And Canada doesn't have access to these new antibiotics either. Now, this looks awful, right? Because all of these new antibiotics are basically unavailable in these countries. But there are some problems here with innovation, which Kevin's going to tell you all about. And only 3 of these antibiotics are included in the World Health Organization's essential medicines list. So maybe it's not so important because Canada has lower resistance rates, low consumption. You might not need all of these antibiotics, but you probably want some of them. You know, we want some of them in Norway. Sweden wants some of them. They have done something about it. And it means that, for example, in Norway, when you have refugees coming from Ukraine that have a completely different resistance profile than Norway, you don't have the right antibiotics available. We don't have them. We have people dying of resistant infections now because we don't have some of these newer and important antibiotics available. So in our work, we've talked about new incentives, and Kevin's going to talk about this. But countries want new antibiotics. They want to ensure that we have antibiotics that treat the infections that we have. But they've got to be accessible. If they're not accessible, then what use are they? So countries have told us that they want new incentives, but they want to make sure that they secure access to both old and new to make sure that the doctors have access to those antibiotics they need. Thank you very much.